Hi, my name is Larry Tannenbaum. I'm the Director of MRI and CT at Mount Sinai Medical Center in New York City. Let's spend a few minutes talking about radiation dose in CT. There's a lot of concern out there in the community about radiation, both in the patient population as well as in the physician circles, about the potential harms of radiation, particularly diagnostic radiation. And that's because we can control the diagnostic radiation, and also because while diagnostic radiation used to make up a small amount of the dose that the population got, today we're about 50% of the dose to the population, and this causes an opportunity to ponder this issue and be concerned about this issue. Aside from concern, there are a number of things that you can leverage, a number of capabilities that you can leverage in your scanner that can impact the amount of dose that you use. We're going to be taking advantage of Care Dose 4D, which is real-time dose modulation in the X, Y, and Z directions. And this can be customized to the actual application and to the facility's biases in terms of how they want to scan. We're going to use Care KV, which based on the scout and the actual goals of our examination is going to make a choice as to what the appropriate KV is, running from as high as 140 to as low as 70 kV, with 70 kV and the 80 kV values being more suited to iodine-based exams, whereas some of the other values, the higher values, may be more suited to other types of exams. And of course, Sapphire, iterative reconstruction, Sinogram affirmed iterative reconstruction, a very powerful tool for getting gold standard images at lower doses. You can see the actual user interface of Care KV. You essentially give it a sense of what your reference KV and your reference MAS should be. And this will vary based on your application. If you're doing low dose lung, you're going to set those values low. If you're doing contrast enhanced liver, you're going to set those values in a different fashion. And you slide that slider over to tell the machine, I know you know what the scout looks like, but I'm telling you now what my goals are in this examination. Is it a CTA? You can probably go pretty low dose and very low KV. If it's a liver, you don't want to make those kind of choices. And here you can see, where we've set our minimum KV and maximum KV along with the slider, and we've actually set the Care KV on. Now, the way these curves work is, they're very complex and they're very sophisticated, and you can set them in a number of different ways in terms of their strength, and that strength really determines how much adjustability is being done and how much consideration is being given, and this will be set up, to the facility's preferences. And you can see, from this particular snapshot, the different settings for the different applications. Another important tool that we use every day is XCare, and this is essentially organ-based dose modulation. And this particular example shows reduction of views of dose when the views are taken with the tube closest to the breast. This also applies when in neuroimaging in terms of looking at the thyroid or in the lens, and we can reduce dose over those radiation-sensitive organs. And this is, again, used routinely throughout our facility. But iterative reconstruction is probably the most all-encompassing, biggest change that we see in terms of dose control. And this is a whole new method of image reconstruction that just does a much better job of managing noise, and while still leaving image quality, where you expect it to be. And frankly, in reality, in many ways, it's a lot better than what we expect it to be. And how can it be better? Well, because we're used to images based on a fairly crude method of reconstruction, which is a filtered back projection. Why are we using a crude method? Well, because the method is a legacy from the days when our computers really weren't fast enough. Commodore 64s, have a hard time reconstructing 150 512 squared images. So we use this quick and dirty method of making an image which is full of assumptions that all contribute to noise, but we get the image very, very quickly, and that was the benefit of this technique. With iterative reconstruction, we start with a filtered back projection approach, fairly crude approach, but then we forward project the data and compare it against the actual data. And we cycle through that comparison and refocusing, comparison and refining approach for many iterations until finally we get an image that we can use in day-to-day practice. And this final image is much, much lower in noise than the data would have been processed with a filtered back projection. And lower noise images essentially create the opportunity to reduce the dose we need for any given noise. So you can say, I end up with an image that looks like my routine image, but I'm able to accomplish that at substantially lower doses because of the iterative reconstruction process. Here you see an example of a sapphire image on the right and a routine filtered back projection image on the left. These are the same patient at different days. And you'll notice that the dose level on the left-hand side is a sort of standard 971 DLP with a CTDI about 48. And you may know that the American College of Radiology guidelines for CTDI run up as high as 75 on the CTDI level. So this is a modest dose exam, but it's what we do in day-to-day practice. On the right-hand side, you see with iterative reconstruction, we can bring our dose down to a CTDI of 17 with a DLP of 300. And what is that? Something like 15% of the ACR guidelines. So substantially lower dose. You can see the images are certainly comparable in many ways, but if you look at the image on the right, the noise level is lower. The gray-white differentiation is better. I mean, easily you can argue that the image on the right is substantially better than the image on the left, yet it is obtained at a substantially lower dose. Now, part of the way we got the dose as low as we did is we used CARE KV to set the KV at 100, as opposed to what we might use routinely across the board, 120 on a routine head. In this case, the machine said, based on your goals, high degree of low contrast detectability and the shape of the patient's head, we can accomplish this with 100 kV and get excellent image quality. Here you see 3 different examples from the same patient on different visits. You have a DLP of 832 on the left, 534 in the middle, 832 on the right. This is one of my neurosurgical ICU patients who had multiple repeated exams. But you can see in the middle, which is the sapphire reconstructed image, we end up with really clearly better quality than the 2 other exams done with filtered back projection. Remember, filtered back projection may be what we're used to, but there's a lot of noise. There's a lot of speculation in those images. There's a lot of salt and pepper that is not real information. It's just noise. The sapphire reconstruction reduces some of that noise, allowing us to get really a better quality image. I mean, a modest claim would be standard quality images, but you can see from this example the images are clearly better and at substantially lower doses. Here's an example of one of my ICU patients. We have the routine approach with a DLP of 951 on the left and the sapphire approach with a DLP of 324 on the right. The CTDI on the right is only 17.7. CTDI on the left is 47. If you look at the gray-white differentiation, it's at least as good, if not better, on the right. The image has a lot less noise in it on the right. And you can see, I think it leaves very, very little to be desired. Frankly, I think it's an improvement over where we were beforehand at the higher doses. And that's the benefit of the sapphire iterative reconstruction. I hope that was a reasonably good survey of how we use these techniques, leveraging both the hardware and the software of the scanner to get our doses right with our image quality as good or better than we've ever had before. Thanks for your attention.